I'm Dennis Campbell. I chair the Professional Advisory Board for the 5P- Society. Today I'm going to provide a brief overview of the syndrome and some research we have done in the United States. Shaw is a rare genetic disorder, first identified in 1963 by Dr. Lejeune in France, also known as cry of the cat syndrome or cat-cry syndrome. Definition is a unique combination of both physical and mental characteristics caused by loss of genetic material on the short arm of the fifth chromosome. Prevalence rate is about 1 in 35,000, and it's the most common deletion syndrome. Here's a picture of a karyotype showing the typical fifth chromosome with the short and long arm and the centromere. And on the bottom in red is a microarray depiction of where that would be on that chromosome. Again, this is a summary of some of the research and the location on the chromosome. You can look at the PowerPoint I sent separately to be able to see this better. I suspect it's not real large on the screen you're looking at now. And some of the genes that have been identified and their location. Some of the data I'm going to talk about today comes from two studies that the Society has been doing over the course of many years. One is a caregiver's guide, and you can see the number of respondents and some information about them. And then the other was a family history database that's been kept for many, many years. Development in Shaw. The genotype-phenotype correlation is there's a tendency that smaller deletions will have less developmental issues. Again, this is just a tendency. Unfortunately, we don't have good enough research to make that a solid statement. And you can see some of the ages. Most children walk independently by 3 years. Anywhere from 15 months to 7 years when they sit up, and etc. About 50% develop some speech. I suspect that number is probably higher now, but again, we don't have current data really to support that. They're able to communicate those sign language, gestures. There's a wide use of tablets these days. Which have been very helpful, at least here in the United States. What we recommend to families is they use what we call a total communication system, where they provide as many different ways for their child to communicate and pretty much support all of them, but the one that the child seems to favor the most. Some development. 46% have different sorts of vision issues, myopia, strabismus being probably the most prevalent, and hearing. 15% had tubes, 8.5% had hearing loss, but probably the most critical thing is overstimulation to sounds, smells, that hyperacusis in most children. Which is can be a real problem for families. Two prevalent behaviors that we've seen in all the data is short attention span, low tolerance for frustration, and hyperactivity. Some others are self-stimulating behaviors. Hand sucking, head banging, skin picking are three of the most prevalent. Again, here's another list of some of the behaviors that we've seen in some of our data, and I'm not going to go through those in the given the time we have. Here's a picture of some of our kids here live locally towards me. This is my daughter Amy, the third from the left. And I'll use her as an example here in a minute. growth, especially for the professionals. Infants and toddlers tend to have an overall slower growth rate. Sometimes it was viewed as failure to thrive. What we found is that these children just are smaller. The 5B Minus Society in the U.S., along with folks in Italy and several other countries, created growth charts a few years ago. And make sure that you get a copy of those so that your primary care physicians understand that they do grow slower and they are smaller. Heads can be microcephalic, though we don't see too much true microcephaly. Have low tone, but not as much as what you would see in a floppy baby syndrome. The most functional challenge is communication. About half of children develop some verbal language, and again, I think that number's probably low. I think it's more than that, but we haven't had any recent studies looking at that. We do know that use of sign language early is effective, and that receptive language develops is much higher than expressive skills. These kids, they understand everything that's going around them, and they're very good at understanding those receptive skills. When we test them, they're usually about a year and a half to 2 years higher in receptive than expressive. Some of the facial features, again, this is my daughter Amy, and you can see the round face, the hypothyroidism, folds, low set ears. She did have some skin tags that have been corrected, and she also had some of the dental issues. We had to do an expander to make her teeth fit because her jaw was a little small. So that's something, again, need to pay attention to make sure that your medical folks understand and that your dental folks understand to kind of watch that, because that small jaw will cause some problems with dental stuff. Picture of some of our adults at a conference here a few years ago, and I suspect that what you see in Colombia and South America are some of the very, very same features. We always say that once you've seen a few children with cri de chat, that you can pick them out in a crowd. Hearing, again, that overstimulation to sound, that hyperacusis, and then some of the vision stuff. They do have advanced social and self-help skills compared to other developmental areas. These kids are really good about getting what they want. I always tell anyone who's working with her that don't worry, she'll make you understand exactly what she needs and be in charge. And balance and motor planning are certainly an issue. Again, having the family history data, there's some of the issues we have. Most of them had the cry. Constipation has been a problem, and there's been lots of different ways to look at that. And if you go and look at some of the Facebook groups and things like that, you can get some ideas, some ways to deal with it. Drooling is always a problem. Feeding, cold hands and feet. That's something that surprises new families. Behavior. One thing that I always tell professionals and people new to the syndrome that these are fun individuals to be around. They're friendly, they're happy, they're very affectionate, they enjoy social interactions, but they do have short attention span and do have some self-stim behaviors that you need to pay attention to. One of the things that we've run into here in the States is the whether or not someone with CDC or 5P minus can also have autism. The issues with autism is they tend to be less social. So our kids have cognitive abilities. They're able to manipulate the environment and people around them. They're very good at that, where a child on the autism spectrum would tend to avoid that. They have selective hearing and selective interactions. They pretty much know what's going on, and sometimes they choose whether or not they want to do that. And they're more like kids with an intellectual disability rather than autism. Though in the States, I tell parents, look, if you can get better services by getting the term autism added, then go for it. Because what we want to do is get the most support we can. Let me talk a little bit about some of the studies we've done. We did a study of assessment of young children aged 3 to 18. We did this over many years. Used traditional assessments, and traditional assessments have are set to where they have a beginning and an end. So when you get to a point where an individual has made so many incorrect choices, we call that the ceiling. For these instruments, we didn't stop at the ceiling, and what we found was that these children had a lot of things going on and had a lot of skills that wouldn't have been picked up if you had stopped at that point. This is important because when you're working with someone to help them become more independent, you don't want to spend a lot of time teaching them things that they already know how to do. And we found that children with CDC in the United States would love that because they tend to be a little lazy, and if they can get away with not doing it, that would be just fine with them. So we ignored the ceiling and looked at the skills that were present. We had a range of 1 to 34 skills per individual we tested. The average was almost 11 skills that we picked up that would not have been picked up if we had done the instrument in the traditional way. These were individuals 35 months to 18 years, and again, the average was was close to 9. We did another study looking at communication using the Battelle Developmental Inventory, and some of them developed skills 3 years beyond what that would have been picked up had they stopped the instrument where they did, and again with expressive language. Social skills were much higher, almost 2 years higher. Some of the things that show is asserting self in a socially acceptable way, recognizing the feeling of others, and then recover from distress in a reasonable amount of time. And they're not, and those are things that would not have been picked up again. And the same for motor skills. I'm not going to go through them in the interest of time. We did another evaluation called the Scales of Independent Behavior. We looked at 63 different individuals, 21 males, 42 females. So parent report instrument range was 2-year-old to 16.5-year-olds, averaged 8.5 years old. It looks at adaptive behavior, and it takes that and problem behaviors and comes up with what they call a support score to help determine the overall intensity of resources that might be needed. And here are some of the support scores. 14% had pervasive scores, which means they required very high intense levels of support. 39% were extensive, so they need continuous support and supervision, but not as intensive. 36% frequent, need close support and supervision, and then again 9% limited, but still they needed that support and supervision. And this is important because when you look at some of the behavior instruments that have done on these individuals, the answer is, did they do it or not? And yes, they do, but it's not as bad as people would think. And we want folks working with our children and adults to realize that, hey, they're very, very easy to work with, and those behaviors, yes, they're behaviors, but they're not as bad as you might think. Part of the CIBAR, they asked a series of questions about some of those behaviors, and you can see here the hurtful to self and hurtful to others. One of the things that you need to note as we flip through these is the frequency. 6 to 10 times a week is not awfully terrible, and it's a mild problem. So parents said yes, they had these things, but we were able to handle it. And the same thing with disruptive behavior and destruction of property, repetitive habits, and socially offensive. Again, they're all about the same time amount per week, and slightly serious, a milder problem. One of the things that we encourage, or I encourage at least, and it was a big topic when we presented some of this in Madrid about a year ago. Inclusion. From our caregivers guide, we saw that 44% were included, 56% were in special classes. Our data on inclusion is probably not the best. The one thing I always encourage is that inclusion is important for social development. If you have an individual who is only in an environment most of the time with other people with non-typical behaviors, they're going to learn those behaviors. Children learn from each other, so we want them learning typical behaviors. And so it's very important that we have them in a situation where they can learn those. And when they finish their schooling, they're going to be, hopefully, in the community with everybody else. And so it's important that they learn how to behave and how to act around other people. And one thing we've found is that's very possible to do with our kids. So again, it's important that they're around other children who do not have disabilities. The one thing I taught teachers, and I've taught teachers for 20 years, is to teach independence. Yes, they may need some help, but you want to make sure that you're providing them with the skills to be independent. So I always taught them to reach for total independence and work as hard as you can, and then settle for as close as you can get. Some of the research studies, again, we've been talking about is we did a study back in 1999, pre-linguistic development, and then we also did one looking at the developmental domains and patterns, the assessment one I talked about, and then looking at the family history database that the 5P Minus International Society has done. Some selective studies. The first one, I was fortunate enough to work with Mary Carlin, who has now passed on, who was one of the premier researchers in 5P deletions. We wrote a topical overview. That's not available online right now, but my email was in the beginning of the slideshow, and I'll be happy to send that to anyone. Again, it's a 2004 version, but it's not that out of date. The bottom two studies, the one by Dr. Nguyen led the study. We did for the American Journal of Medical Genetics. Current Knowledge and Future Directions is a very, very good study and provides a lot of information and really a very good summary of current research. And then also the study from Italy with Dr. Menardi, the natural history of Cretishaw, provides a lot of good information. Those are just a few. There are hundreds of studies on Cretishaw, but those are some of the ones that I find the most helpful. Okay, well, thank you for inviting me to present. I hope this was helpful. Again, it was fairly quick, but I have sent along to the PowerPoint slides, and so you can delve into those a little more at your leisure. Thank you again.